This is the beginning of Unit 6, and Unit 6 is composed of chapters 15, 16, 17, 18, and 19, and we will review those here. And they're all, of course, related to blood vessels, blood pressure, the heart, and the anatomy of the heart. And so they're all very similar, of course. Chapter 15 is blood. Blood is composed of two parts, the plasma and the formed elements, which are blood cells and cell fragments. The plasma is a pale yellow fluid mostly composed of water. It also contains proteins, ions, nutrients, gases, and waste. The plasma proteins consist of albumin, clotting factors, antibodies, and complement proteins. In general, plasma proteins help regulate fluid volume, protect the body from pathogens, and prevent excessive blood loss in the event of injury. Serum is the plasma minus the clotting proteins. The blood cells and cell fragments include RBCs, or red blood cells, also known as erythrocytes. Erythro means red. Red blood cells are primarily involved in the transport of oxygen to all the bodies, which you know. They're also the most numerous of the blood cells. White blood cells are called leukocytes. Leuko means white, and they protect the body from infection. Platelets are called thrombocytes, and they protect the body from bleeding. In the lab, when blood is separated into two phases, it forms the basis of a blood test called a hematocrit, an HCT. Physicians will order hemoglobin and a hematocrit. The hematocrit is considered the packed cell volume. It's the percentage of blood cells in that sample of blood. The process of blood cell formation is called hemopoiesis. The two types of hemopoietic tissue in the adult are the red bone marrow and the lymphatic tissue. The red bone marrow is found primarily in the ends of long bones, such as the femur, and in the flat, irregular bones, such as the sternum, cranial, vertebrae, and bones of the pelvis. Red bone marrow produces three different types of blood cells, and they all come from the same cell, a stem cell. If bone marrow activity is altered, it creates myelosuppression, or bone marrow suppression, and polycythemia, or bone marrow hyperactivity. Red blood cells are filled with a large protein called hemoglobin. It consists of two parts, globin, which is the protein, and heme, which is the iron. Heme is most important because as the red blood cells circulate through the blood vessels in the lungs, O2 attaches loosely to the iron atom in the heme. The oxygenated hemoglobin is referred to as oxyhemoglobin. Then as the blood flows to the various tissues in the blood, the O2 detaches from the hemoglobin. The unloaded O2 diffuses from the blood to the cells, where it is used during cellular metabolism. New red blood cells are constantly added to the circulation, and old, worn-out red blood cells are constantly removed. This regulation is due to the production of erythropoietin hormones secreted from the kidneys. They sense a need for additional oxygen. The erythropoietin stimulates the bone marrow to produce additional red blood cells. There is a drug called EPO that increases red blood cell production, thereby increasing the amount of oxygen delivered to the person who it might be chronically low oxygen. And EPO is a drug that if they're anemic or if they're in heart failure, they often will become anemic. If they have, there's some diseases called hemochromatosis, and that causes you to be anemic. So the patients receive EPO, and it's through an injection. It's usually once a month, maybe once every 2 weeks, and that helps them make more red blood cells. Old red blood cells are recycled. The globin is broken away from the heme, which breaks down into iron and bile pigments. The iron is stored in the liver until it is needed by the bone marrow for the synthesis of new hemoglobin. The liver removes the bile pigments, especially bilirubin, from the blood and excretes them into the bile. Jaundice is caused by hemolysis, which is the breakdown of this. White blood cells, or leukocytes, are large round cells that contain a nuclei. white blood cells lack hemoglobin and are less numerous than red blood cells. They primarily protect the body by destroying pathogens, removing dead tissue and other cellular debris by phagocytosis. When an infection is present in the body, the numbers of white blood cells increase, called leukocytosis. Please review Table 15.1 regarding this process. There are two types of white blood cells, granulocytes that contain granules and agranulocytes. There are three types of granulocytes, neutrophils, basophils, and eosinophils. When you do a complete blood count, you will see the breakdown of white blood cells and then red blood cells, and you'll see it even broken into neutrophils, basophils, and eosinophils. So the physician will study each one of those to figure out what might be wrong with the patient. Hemostasis is the prevention of blood loss. Injury to a blood vessel causes bleeding. Bleeding usually stops spontaneously when the injury is minor. The process that stops bleeding is called hemostasis. Three events are involved in hemostasis: blood vessel spasm, the formation of a platelet plug, and blood clotting. Formation of the blood clot is a result of a series of reactions, and that's called the clotting cascade. And there is a description of that on page 294 and 295, and you really need to read that. The cascade is in three steps. Injury to the blood vessel wall activates various clotting factors. They produce a prothrombin activator called PTA. In the presence of calcium, platelet chemicals, and PTA, prothrombin is activated to form thrombin. Thrombin activates fibrinogen. Activated fibrinogen forms the fibrin fibers or fibrin net. This net traps other blood cells and particles to form the clot. Clot busting is called fibrinolysis. The dissolving of a clot is called fibrinolysis. A substance called plasmin gradually dissolves the clot. Plasmin is formed from the inactive form plasminogen, which normally circulates within the blood. Tissue plasminogen activator, or TPA, formed by injured tissue, activates plasminogen. Please look at figure 1510 and 1511. Antiplatelet drugs interfere with hemostasis. Antiplatelet and anticoagulants are two groups of drugs used for this purpose to prevent excessive clot formations. A third group of drugs is called fibrolytic agents, and they dissolve the clots. So there are antiplatelets and anticoagulants, and they prevent clot formations. And then there are fibrolytic agents that dissolve the clots. You need to know the difference between those two. A blood clot is called a thrombus. The process of blood clot formation is called thrombosis. A piece of the thrombus can break off, making a traveling blood clot called an embolus. The embolus can lodge in smaller blood vessels of other organs, blocking the flow of blood to that organ, such as pulmonary infarct, heart attack, or a stroke. So if that blood clot breaks off, becomes an embolus, and it travels, then it can cause a heart attack or all kinds of things. A common killing disorder called a deep vein thrombosis is particularly lethal. A clot is deep in the veins of the legs, and it gives rise to an embolus. The embolus travels to the lungs, where it can cause death. And as a nurse, and you will need to really watch your patients, need to exercise their legs, get them to do circulations with their feet, and if they're in post-op surgery or on a post-op surgery floor, you will have a machine that you put on their lower legs that gives them pressure and that keeps that blood flowing and doesn't let it become stasis and form a blood clot in their leg that can travel into their lungs, heart, or brain. Thrombosis, this blood clot, can be prevented by the administration of two types of anticoagulants, heparin and warfarin. And normally, if they're in the hospital, they're on heparin. If they're home, they're on warfarin, or it's called Coumadin. They both interfere with the clotting scheme. People who have atrial fibrillation, which is a heart arrhythmia, are usually on warfarin or Coumadin at home. And so atrial fibrillation, we'll study it in a little bit, but it's where the heart is beating irregularly, and because of that, the heart is not emptying correctly, and the blood can pool in the bottom of the heart, and then that blood can form a clot. And so to prevent that patient from having a stroke or throwing that clot out of their heart, they're on Coumadin or warfarin. Now, that drug itself is fairly safe, but you have to watch their blood levels really closely so that you're keeping that blood anticoagulated at a certain rate. You don't want it too thick or too thin, and the physician will monitor that closely. So patients who are on warfarin or Coumadin are at great risk for hemorrhaging, because if they're elderly and they were to fall and hit their head, they can have a brain hemorrhage, because you have decreased the ability of the blood to clot. And so you have to be real careful with these patients. They're at risk for a bleed. And then there's new meds on the out nowadays. One is called Plavix, and you'll see that advertised on TV. And Plavix is another anticoagulant that has less side effects than Coumadin or heparin, supposedly. And the patient, more expensive, but the patient is not supposed to have to go in and have this PTT level done to see how thin or thick their blood is on Plavix. They don't have to do that. The problem is if they have a bleed, you give potassium to a patient who's having a bleed, and that can thicken up that blood and prevent that bleed from getting worse. On Plavix, potassium does not reverse a cerebral bleed. So there's pros and cons to each one of those medicines. Another category of drug is called a clot buster or a fibrinolytic agent, and this is the one that dissolves the clot. So these drugs are different than heparin or Coumadin because they actually can dissolve the clot. One is called TPA, and it has revolutionized the treatment of heart attacks caused by blood clots in the blood vessels of hearts and strokes. And when I was nursing, TPA was first on the market, and we were terrified of it. And now I think it's given pretty much routinely in ERs. That patients coming in with a heart attack or a stroke, they're given that, and that dissolves the clot. What it does is it dissolves a whole lot of other blood clots that are in the body. So it's got a lot of dangers associated with it. So there's a strict criteria as who can receive TPA, and they can't have had recent surgery, all kinds of criteria. But it definitely saves lives when that patient is coming in with an active heart attack or an active stroke. It's called TPA. Blood types. Blood is classified according to specific antigens on the surface of the red blood cell. An antigen is a substance that the body recognizes as foreign. So an antigen is foreign. As a foreign substance, it stimulates an antigen-antibody response. This response is designed to attack and destroy the antigen. The ABO grouping contains 4 blood types: A, B, AB, and O. The letters AB refer to the antigen on the red blood cell membrane. Table 15.3 describes this relationship of antigen. A person with type A blood has the A antigen on the RBC. B has the B antigen. AB has both, and O has neither. In addition to the antigens on the red blood cell membrane, specific antibodies are found in the plasma of each blood type. A person with type A has anti-B antibodies. A person with B has A antibodies. A person with AB has neither A or B, and O has both. Agglutination occurs when the clumping of blood occurs because of the antigen-antibody interaction. This causes red blood cells to burst, called hemolysis, and death to occur. Thus the reason for so many cross-references before giving blood to a patient. So when you go down to get blood from the lab, there are double checks in the lab to make sure it's the right patient and the right blood. And then when you get back on the floor, it requires 2 nurses to check that blood. And in most hospitals, I think only RNs can give the blood, but the double checks have got to be done, and because you can cause hemolysis and kill a patient if you give them the wrong type of blood due to that antigen or antibody. So a patient who has a type A blood can receive A blood or O. Type A blood does not contain A antibodies and does have the A antigen. Type O blood is the universal donor because it has no antigen but has both antibodies. AB blood type can receive all 4 types of blood, so this person is called the universal recipient. Their blood has both antigens and no antibodies. And then the RH classification, this is about a mother who is RH negative and her first baby. If it's an RH positive baby, the blood can cross the placenta and go into the mother, and this stimulates the mother's immune system to produce anti-RH antibodies. So if the mother has then becomes sensitized during her first pregnancy, if the mother becomes pregnant for the second time with an RH positive fetus, the anti-RH antibodies move from the mother's circulation back to the fetus, and these anti-RH antibodies attack the fetus's red blood cells, causing agglutination and hemolysis, and therefore the baby can die. You will study more about that when you do maternity. Erythroblastosis fetalis is what this is called, and this can be prevented by the administration of RhoGAM. So normally, if they know you're Rh negative after your first pregnancy, you will receive a RhoGAM shot, and then this prevents erythroblastosis, and so that's a good thing that they have found now. I've been doing it now for years. Moving on to chapter 16, the anatomy of the heart. The heart is a hollow muscular organ. It weighs less than 1 pound. The apex is the lower pointed end of the heart. The heart is made up of 3 layers: endocardium, which is innermost, myocardium, the middle, and epicardium is the thin outermost layer. The heart is supported by a sling-like structure called the pericardium. At times, the pericardial membranes can become inflamed, and this is called pericarditis, and is characterized by severe pain and a sound called a friction rub. And the friction rub sounds like if you're rubbing sandpaper. You can hear it with your stethoscope over the heart. It sounds like a sandpaper down by the apex of the heart. Patients can get a fluid buildup called pericardial effusion, and that can compress the heart and lead to a cardiac tamponade, which is, for lack of a better word, the heart explodes, and of course this causes death. When a patient has pericardial effusion, the physician inserts a long needle into the pericardial sac and pulls that fluid out and eases that pressure on the heart, preventing cardiac tamponade. I've seen both happen, and it's something that you do not want to witness, and but it's amazing how once they pull that fluid out from around the pericardium, the patient is relieved of a lot of that pain. The myocardium enables the heart to pump blood. The heart is a double pump that beats as one. On the right side of the heart is the unoxygenated blood, and it pumps blood into the lungs to pick up oxygen and get rid of carbon dioxide, which you know. The left side receives the oxygenated blood and pumps it to our organs. So look at figures 16.3 and 16.4. The heart has 4 chambers, 2 atrium and 2 ventricles. The atria are the upper chambers and receive the blood. The ventricles are the lower and they pump out the blood. The PR interval represents the time it takes for the cardiac impulse to travel from the atrium to the ventricles. So when you look at the electrocardiogram, the first little hump you see is what they call the PR interval. And then it's the QRS, which is the tall spike, and then the ST is the last little hump. And we measure each one of those sections, and that gives the physician information that they need to know what's going on with the heart. So they'll measure the PR interval, the QRS, and what they call the ST. And so if the PR interval is longer than it's supposed to be, which is 0.20 seconds, then there's something going on that's causing a delay in the electrical impulse to go through the heart. If the QRS is widened, then we know that there's some damage going on in the heart. Either they're having a heart attack or their heart is failing. If that QRS is widened. If the ST segment, if that is elevated higher, then either that patient has had a heart attack before and they've got damage to their heart, or they're getting damage to their heart. And there is a type of a heart attack called a non-ST elevated MI, and a non-ST means that does not elevate, and so damage really didn't occur to the heart. So the patient was really lucky and they had maybe a mild heart attack with no what they call it's called a non-ST elevated heart attack. So those all of those bumps on the EKG rhythm will tell you something. The cardiac cycle, and moving on into chapter 17, is the sequence of events that occurs during one heartbeat. That's the cardiac cycle. It is the contraction and relaxation of the chambers of the heart. The systole is contraction, in which it's pumping blood out. The diastole is relaxation, in which the blood chambers fill. Atrial and ventricular muscle activity is closely coordinated. During atrial systole, the ventricles are in diastole. There are 3 stages of the cardiac cycle: atrial systole, ventricular systole, and diastole. In atrial systole, the atria contracts and pumps blood into the ventricles. The AV, or the atrioventricular valves, are open and the ventricles are relaxed. In ventricular systole, the ventricles contract and blood is forced against the AV valves, causing them to shut. The blood pushes the semilunar valves open, allowing blood to go to the pulmonary trunk and the aorta. During diastole, for a brief period during the cardiac cycle, both the atria and the ventricles are in diastole. They're both resting. Blood flows into the atria because the AV valves are open at this time. Much of this blood also flows passively into the ventricles. The period of diastole, therefore, is a period of filling of blood. Atrial systole follows, and then the cycle repeats itself. So remember that the cardiac cycle is the sequence of events that occurs during one heartbeat. So all of that is one heartbeat. The sounds made by the vibrations caused by the closure of the valves are called the heart sounds. And when valves become faulty, the sounds change. Abnormal heart sounds are called murmurs. So when those valves are not shutting tightly, there is blood that can ooze through those valves, and that causes a murmur. The first sound in a normal heart sound is called the lub, and that's the closure of the AV valves. The second is the dub, and that's the closure of the semilunar valves. The purpose of the heart valves is to keep the blood flowing forward. You don't want backflow of blood. That's going to cause lots of problems. The SA node is located in the upper posterior wall of the right atrium. An electrical signal originates within the SA node. The electrical signal is called the action potential, or the cardiac impulse. The SA node fires an impulse of 60 to 100 times a minute. Because the firing of the SA node sets the rate at which the heart beats or contracts and relaxes, the SA node is called the pacemaker of the heart. If the electrical signal originates outside of the SA node, it is referred to as ectopic. And the important thing to know about the SA node, as I told my patients and the doctor explained to me, the SA node is the pacemaker, so it's like the light switch of the heart. It starts that electrical impulse. A patient who has atrial fibrillation, for an example, the best way to explain it is they have more than one light switch. So this light switch might go on, the next beat a different light switch, the next beat a different light switch. And so what you will see on the patient's EKG is they'll have varying widths of their P wave on the EKG. So they'll it'll be irregular, their heartbeat will be irregular, and sometimes it will be very fast. So what does that cause? Well, what that causes is when that heartbeat starts being irregular, the ventricles are not emptying fully, and the patient is at big time risk for a stroke because that blood pools in the bottom of the ventricles, and that can cause the blood to coagulate and form a clot, and the next beat or whenever that patient may throw that clot out into their system. So these are the patients that you will have that are on Coumadin or warfarin, and then they have to have all the blood work done, etc. But that keeps that blood from coagulating down in the bottom of the ventricles of their heart. So the SA node is very, very important. It is the pacemaker of the heart. It starts the firing, and it's normally 60 to 100 beats a minute. If it gets out of pace, then that's when you start having heart problems, heart blocks, atrial fib, all kinds of different things. And then this pathway of the cardiac impulse, it goes from the SA node to the AV node, to the bundle of His, to the bundle branches, to the Purkinje fibers, and then that triggers depolarization. The SA node fires and the P wave reflects the electrical activity on the electrocardiogram. The PR interval shows the length of time to ventricular depolarization, which is the QRS complex, and then depolarization precedes and triggers contraction of the heart muscle. The T wave reflects the electrical activity associated with ventricular repolarization, and I explained that all to you earlier about the EKG. How the parasympathetic nervous system affects the heart. Remember, parasympathetic slows things down. In the resting heart, vagal tone is more intense than sympathetic activity. The SA node might want to speed its impulse and beat the heart at 90. The vagus nerve from the parasympathetic slows the SA node fire to a rate of 72, which is a normal resting heart rate. If the vagus nerve is interrupted, the SA would increase back up to 90. And certainly people that have problems with their heart rate may need to take some sort of a parasympathetic drug, and certain conditions such as heart attack and certain drugs can cause excess vagal discharge and really slow down that heart rate. Excess vagal discharge causes bradycardia, which is less than 60, and can lead to life-threatening events and heart blocks. And your patients who are in atrial fibrillation are given a medication called digoxin or lanoxin, and that is a med that will slow the heart rate, because a lot of patients that are in atrial fibrillation, their heart rate gets really fast, like 140. They'll just say, my heart is racing. They get diaphoretic. They get dizzy, they get whatever, they have a lot of trouble with their heart rate. So these patients are placed on digoxin or lanoxin, and that keeps their rate slower, and it enables the heart to forcefully contract better, and patients can have more success with managing that atrial fibrillation. Cardiac output is the amount of blood pumped by the ventricle in 1 minute. The normal cardiac output is about 5 liters a minute. It's a lot. Because the total blood volume is about 5 liters or 5,000 milliliters, the entire blood volume is pumped through the heart every minute. Venous return is the rate of blood back to the heart. 2 factors determine cardiac output: heart rate and stroke volume. Heart rate is the number of times the heart beats per minute, and stroke volume is the amount of blood pumped by the ventricle per beat. An average resting stroke volume is 60 to 80 milliliters a beat, or about 2 ounces. So remember, the cardiac output is the amount of blood pumped out in 1 minute, and it's determined by heart rate and stroke volume. And stroke volume is the amount of blood pumped out with every beat. So if it were 60 times 60 is what, 4,800, so almost 5,000 milliliters per minute. And how can you change this stroke volume? Certainly the heart rate would, but would change the cardiac output, but the stroke volume is changed by Starling's law. And Starling's law is the relationship of the myocardial stretch, or the heart, and the myocardial contraction force. So the force that the heart can stretch, the force that the heart can pump blood out, and the amount of stretch the heart has. The greater the stretch of the myocardium, the stronger the force of contraction, kind of like pulling a rubber band and snapping a rubber band. Strengthening the force of myocardial contraction without stretching the myocardial fibers is called positive inotropic effect. Stimulation of the heart muscle by sympathetic nerves causes a positive inotropic effect. Certain hormones and drugs, such as epinephrine, can also cause this. The most famous positive inotropic drug is digoxin. So it helps helps cardiac output, the med itself, because the heart doesn't have sometimes the strength to forcefully push the blood out. So patients that are in heart failure are on digoxin, because that helps the myocardium with that force that it needs. Now the thing about digoxin, and you will learn, and you must never forget, is that digoxin slows the heart rate, as I said, and before every dose of digoxin you have to take the apical pulse, and you measure it for 1 solid minute, and if it's less than 60, you hold the dose and call the doctor, or you do what your facility tells you to do, but you never give digoxin without taking the pulse, ever. Some terminology: end diastolic volume, that refers to the amount of blood in the ventricle at the end of the resting phase, or diastole. The end diastolic volume determines how much the ventricle is stretched and is the basis for Starling's law. Preload is the amount of blood in the ventricles at the end of diastole. It is the same as end diastolic volume. An increase in preload stretches the ventricles, causing a stronger force of contraction. The stronger contraction increases stroke volume. So it's the amount of blood in the ventricles at the end of diastole when the ventricles have rested. And that amount of blood causes the stretching. And that then causes Starling's law, which increases stroke volume and cardiac output. The ejection fraction is when the ventricle contracts, it pumps about 67% of the volume that is in the heart. Therefore, some of the blood remains in the heart. So the heart doesn't pump out 100% of its blood all the time. The percentage of the end diastolic volume, the amount of blood that's in the heart that is pumped, is called the ejection fraction. And it's an indication of cardiac health. So 67% is around normal. If your patient is around 30 or 40, they're probably in some sort of heart failure. And so you think about it, they're not pumping out all of the blood that they need to pump out of their heart because their heart is weakened, either from a heart attack or heart failure or whatever. And so they would then receive medication that helps them get that blood pumped out of their heart. Afterload refers to the resistance or the opposition to the flow of blood. So an example is hypertension. Afterload increases and with hypertension, afterload increases. So with hypertension, there's more pressure that the heart muscle is having to push against to get the blood out of the heart. So that's why hypertension is so dangerous, because the heart is having to work so hard to push the blood out of the heart. And over time, that heart is a muscle, and it will build up in the thickness of the wall of the myocardium will build up, because it's a muscle, causing the ventricles to be smaller, able to pull in less blood, able to pump out less blood, and then it's just that vicious cycle. So that's why it's so important for us to monitor our patients that are hypertensive and get that blood pressure under control. Inotropic effect is a change in the myocardial contraction that is not caused by stretch of the myocardial fibers. A positive inotropic effect is an increase in contractile force, and a negative inotropic effect is a decrease in force. As we mentioned earlier, epinephrine causes a positive inotropic effect. Epinephrine causes that heart to pump harder. Left heart failure. When the left ventricle fails to pump blood into the aorta, two things happen. Blood backs up in the lungs, and the heart is unable to pump a sufficient amount of blood into the systemic circulation. This then forces fluid into the lungs, which impairs oxygen, and that is called pulmonary edema. If the left ventricle is damaged and cannot pump blood to the systemic circulation, all of the organs of the body receive inadequate oxygen. Kidneys fail, causing edema, etc. So left ventricular heart failure, you'll see patients who have fluid in their lungs, they have edema, the kidneys start failing. And one thing that I learned in nursing school, when I was in nursing school, is that we have two kidneys, and so the kidneys, in all their wisdom, know that they can live on one kidney, and they will shunt the blood away from the kidneys and send the blood to the heart and to the brain, which must have the oxygen from the blood. So you will see patients in kidney failure a lot of times first, because the kidneys are shunting the blood away from them and trying to save the heart and the brain. Amazing. And so what usually causes left ventricular failure? Of course, a heart attack and hypertension are the two big ones. Right-sided heart failure, when it fails, blood backs up into the veins that return blood to the right part of the heart. It backs up into the superior vena cava, slowing venous drainage from the head, and therefore you'll get distended jugular veins. And blood backs up into the veins that drain the liver, the spleen, digestive organs, causing hepatomegaly, which is an enlarged liver, splenomegaly, which is an enlarged spleen, and digestive systems, and a lot of ankle edema. So please, there are charts there you need to know the side effects of right and left-sided heart failure. Chapter 18, Anatomy of the blood vessels. Pulmonary circulation carries blood from the right ventricle of the heart to the lungs and back to the left atrium. The pulmonary circulation transports unoxygenated blood to the lungs, where oxygen is loaded and carbon dioxide is unloaded. Oxygenated blood returns to the left side of the heart to be pumped into the systemic circulation. Systemic circulation carries blood to the rest of the body. The systemic circulation carries oxygen and other nutrients to the cells and picks up carbon dioxide and waste. Table 18.1 discusses these structures and functions. When the ventricles pump blood into the arteries, the blood causes an alternating expansion and recoil of the arteries. With each beat of the heart, this causes a pressure wave or a vibration which travels all through the arteries. This wave is what we call the pulse that we feel. So that's a vibration that's caused when the ventricles are pumping blood through the arteries. You need to study the pulse points on figure 1810. And in chapter 19, functions of the blood vessels, they have 5 important functions. They act as a delivery system, regulate blood pressure, engage in exchange of nutrients, redistribute blood, and help regulate body temperature. So as a delivery system, blood vessels help deliver oxygen. Impaired blood flow and oxygen deprivation is called ischemia. So if the patient comes in and they're having chest pain, we say they're having an ischemic attack because the heart is crying for oxygen and it can't get it for some reason or another. So they're having an ischemic attack, and we'll give them nitroglycerin, which helps dilate the vessels and enables that oxygen to get to the heart and hopefully prevent a heart attack. Blood pressure, this is the force that blood exerts against the walls of the blood vessels. Pulse pressure is the difference between diastolic and systolic pressures. You've studied blood pressure in your lab, so I'm sure you know all these terms, but remember the effect of resistance on pressure. Low resistance in a vessel, there's low pressure. High resistance in a blood vessel, there's high blood pressure. Vasodilation expands, and that causes low resistance and low pressure. Vasoconstriction is like a water hose. There's high pressure and high blood pressure. Several hormonal mechanisms act slowly to control blood pressure, such as the renin, angiotensin, aldosterone mechanism. Activation of this mechanism increases blood volume and causes vasoconstriction. And the hormone, antidiuretic hormone, is a vasopressin, so it increases blood pressure. So it's antidiuretic. It does not unload the fluid, and it's a vasopressin, and it increases blood pressure. And you will read about that in pharmacology. Blood vessels engage in the exchange of nutrients and waste between capillaries and cells, and they redistribute blood in response to changing body needs, and they help regulate our blood temperature. So that is an overview of Unit 6, blood and heart and structures, and I hope I'm able to help you understand it just a little bit better, and thank you very much.